I put this up here mostly because I saw a talk the other day about the articles that I'm going to talk about, and I was dismayed by it. You know, there's a bunch of different ones. So I wanted to talk about them because I think TXA is sort of getting the short shrift with a lot of this stuff. So what is TXA? TXA is tranexamic acid. How it works, what it does. TXA is an antifibrinolytic. So instead of, it doesn't make you clot more, like here's the whole clotting cascade and who cares, honestly. What it does is prevent clot breakdown. So if you look at this very bottom little part here, where plasminogen turns into plasmin, which breaks down a fibrin clot after you form the clot, TXA essentially is opposite of TPA. It works at the same site and prevents plasminogen from turning into plasmin. So you don't break down clots quite as fast. Now, it's not like a really big dramatic push. It's not like it totally shuts it off, probably. It's more like things just don't quite go as fast. So if you remember, good, it worked. This scene from classic movie Cool Hand Luke. Let's see if he gets up there. Here it comes. Yeah, it's not doing it. Anyway, if you remember, they're digging this ditch. They make him dig this ditch. And then every time he digs a ditch, they make him fill back in. And then when they come, another guy will come back and say, what's all this dirt doing in boss's hole? And so he keeps filling this ditch and digging this ditch back, digging this ditch again. And long story short, that's what your body's doing. You're constantly laying down little bits of clot and then constantly picking up little bits of clot. And that's just the way that you maintain homeostasis. So TXA basically makes it a little bit harder for your body to break down clots once you form them. It makes your clots a little bit tougher. That's useful for bleeding folks is the big idea. So since the 1960s, this has been used in obstetrics and in heavy bleeding for periods. You can buy it in Japan over the counter right now if you have heavy periods for menorrhagia. It's a pretty safe drug, works pretty well. It's actually pretty effective. It's not very expensive. It's about $70 a pop, if I remember correctly right now. And it's been studied fairly extensively in a surgical setting. So orthopedics, cardiac surgery, lots of other stuff. There have been a lot of studies, a bunch more since this. There's now like 140 odd studies that show that TXA actually keeps you from bleeding as much and that you have to get fewer blood transfusions and you don't soak as many ABD pads or whatever if you get TXA. And by the way, there's been no increase in clotting that's been shown. Specifically for trauma, which is the thing we want to talk about because most of us still aren't given like TXA just for whatever. Mostly we're giving it for trauma. That's the big push right now. So a couple of studies on that. The CRASH 2 study, which was back 2010, if I remember correctly. This was a study over about 40 countries, 220 some odd different hospitals, enrolled about 20,000 patients, and they gave them, it was a RCT, so you either got placebo or you got TXA. And the folks that got TXA had a significant mortality benefit. Cool. And that mortality benefit is extended a little bit more if you have bleeding, but it's also there even if you don't die from bleeding itself. And then a couple of sub-studies of it later showed that actually the benefit is most pronounced if you give it within 3 hours. And if you wait more than 3 hours, then you actually run the risk that you develop a little bit more venous thromboembolic disease like PEs or strokes or that kind of stuff. But CRASH 2 was a big old study that showed there was benefit to giving TXA in trauma. The criticism of CRASH 2, unfortunately, and there's always criticism, and this is probably not really well met, the criticism is that it wasn't done in the United States. It was done in countries, primarily in like third world countries in Africa where there wasn't a developed trauma system. And, you know, I guess you could make the argument that, yeah, perhaps people in Africa are physiologically different than people in the United States, or people in Eastern Europe are physiologically different than people in the United States. But that's not a very strong argument. And so to say that it may not help bleeding in the US, maybe is not the thing we actually should be making the argument on. And you can sort of pick apart CRASH 2. It's a big study. It's a pragmatic trial, so they didn't look at a bunch of different variables on it. They mostly just looked at a few odd things and just had such high patient numbers that they accounted for all the variability in that. So some folks will still criticize CRASH 2. There's probably not a great reason for it. A couple other studies have been done in the meantime. The MATTERS trial was a retrospective observational trial. This was military folks, basically folks that got TXA had, again, a significant survival benefit. And that survival benefit was almost doubled if you looked at folks that had massive need for massive transfusion. This was a military study, so people will criticize that because it's young, healthy guys that got IEDs or got shot, but they're still bleeding, so they're still at. And then the woman trial came out in 2017. This was one of the more recent ones, and this wasn't trauma. This was actually maternal bleeding. So postpartum hemorrhage, again, gave TXA, and there was a significant survival benefit. Now, we're not talking about like huge survival benefits. It's not 50% benefit. It's a relative risk reduction of death by like 0.8 or something like that. You go up from you go from like a 1.9% death down to like a 1.5% death. So the relative risk reduction is still there, just the absolute numbers are not that great. But when you figure, if you're looking, like woman was, again, about 20,000 patients, 0.5% of 20,000 patients is somewhere around 100 patients. So that's a regional jet full of people that you give a cheap drug to and they don't die. If there was anything else that would say we can prevent one regional jet plane crash a year, you know, if you said that mountain's in the way and our jets keep crashing into it once a year, you'd bulldoze the mountain. But this is just giving a cheap, safe drug. So, so there's a fair amount of data behind bleeding and TXA being a good thing. Who should get it? Probably anybody that's at risk for death due to bleeding. One of note, a lot of these trials have relied on saying the indication for this is if you are not sure that the patient should get TXA, you enroll them in the trial. If they thought the patient would definitely benefit from it, they didn't enroll them. If they thought the patient would definitely not benefit, they didn't enroll them. It was just the guys that had some equipoise in the middle that are the ones that actually entered these trials. So sort of interesting. By the way, I'm just doing a quick little run through of this stuff real quick, because the thing that I actually wanted to talk about was this one. This is a paper about TXA that was published, just 3 months ago. It's in a little journal called The Lancet. You may have heard of it. It's a pretty big name. And these guys took the CRASH 2 data and the data from the woman trial, which again is about 20,000 patients each, so 40,000 patients, and put them together, got all the data, and analyzed it as one big study. So there's a meta-analysis. Meta-analysis is a fine way to do a study, by the way. Just because they're a little bit different doesn't mean you can't actually use them. So these guys looked for studies, RCTs with more than 1,000 patients, of which, again, there are two. It's woman and CRASH 2 for folks that got TXA. Their outcome was deaths due to bleeding. You could say all-cause mortality, that data was available, but deaths due to bleeding was the thing they really wanted to look at because it's the most homogeneous between the two. And then as a secondary outcome, they looked at the risk of vascular thrombotic events, so things where you got clots that flicked off from one place or another. You could argue that probably an MI isn't a vascular thrombotic event. Well, it's a thrombotic event, but it's not like you don't get a clot in your leg and it goes up and hits your coronary. So you could question whether or not that's actually supposed to be in there, but it's there nonetheless. And then they also looked at the time delay to treatment and made a model out of that. What are the results? Well, the folks that were in the folks that were in this study were relatively ill. So about 40% of them were frankly hypotensive. The rest were bleeding pretty significantly. You don't have a whole lot of variables in here because, again, big study, lots of heterogeneity. But they're relatively sick. And they were caught relatively early on. About 70% of them got TXA within 3 hours or so. Here's the results. Death due to bleeding of almost any cause is significantly decreased when you got TXA. Again, not a lot. You're looking at 9.3 versus 8.4%. But out of 40,000 patients, that, again, is now just not one regional jet. It's about, 4 regional jets, something like that. And that's statistically significant. They also found no increase in thrombotic events. So no clotting, no problems with clotting in any of these 40,000 patients. No significantly increased changes in the amount that you clotted, that is. So it seems like it's safe. It seems like it benefits people. You've got a cheap drug that we've now got lots of data that says this is probably a good thing. And they actually generated this curve that looked at the time from when you started bleeding to the time that you got TXA. And it was about 15 minutes in where you dropped down to about 90%. What's this all mean? It basically says TXA is a good thing. It's pretty safe. And for every 15 minutes you wait, the effectiveness of it drops by about 10% down to, they demonstrated the same thing as CRASH 2, down to about 3 hours when it stops really having a benefit. So if you're going to give TXA, you should give it early, and you should give TXA. That's what this study says. We'll just skip over that for a second. Cool, huh? Cheap drug. Easy to give. I mean, you put it in a 100 cc bag and you just let it drip in over about 10 minutes. Doesn't have a lot of side effects. Seems pretty safe. Awesome. There is going to be a statement coming out by the Board of EMS that's essentially anti-TXA, which is one of the reasons I want to talk about this. They're going to say, no, we don't like this thing, and you probably shouldn't give it to people, and we're not going to take it away from anybody, but we're not going to approve any new TXA protocols. And you may say, well, what the hell is going on? There was this paper that was put out last year as well, and this is one of the other really important papers. So the the meta-analysis between Women and CRASH 2 and this are big important papers. This isn't an important paper because, and I'm biased, I will admit, this isn't an important paper because it's all that great. It's important because people are paying attention to it and misinterpreting it, if you ask me. So this was a thing that said, hey, there's this thing that we can get called a TEG, which is a measure of how strongly you form clots when you're bleeding or just for whatever. And the way that you read this thing basically is you have a little cup full of blood and you have this little spinny like thing that sits in the middle of it. Take your cup full of blood, thing goes down into it, machine starts spinning, goes and spins really fast. And after a short period of time, a clot starts to form around it. And you get the strength of that clot is what's being graphed on this curve. So spinning, 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 clot forms, we make a big, big spike in strength. And then as time goes on, that thing continues to spin. The clot gets a little bit less and a little bit less as fibrinolysis goes on. And eventually it goes back to liquid, so you dissolve your clot. That's the way that things normally look. The concern in most trauma settings, the things you would think is bleeding, right? You're worried about bleeding, and then there's like the triad of death where they get cold and they bleed more, and they go in shock and they bleed more. And so you generate a TEG that looks more like this. So the thing spins, you make a strong clot for a second, but then it gets lysed all of a sudden. It goes away really quickly. So that's hyperfibrinolysis. That's the thing that we think TXA might help. However, some folks will say that probably there's a group that doesn't lyse at all, that they form a clot and then it just kind of chills out for a while and doesn't really go away. Maybe because you use up all your plasmin or whatever. But this idea of fibrinolytic shutdown has come out in the last probably 3 years or so, and the trauma guys are really into this. And maybe it's a thing. It seems to be a thing. It at least generates a lab value. So yeah, it's probably actually out there. This study was based on the idea that that's there, and we don't know if TXA, we don't know what TXA does in that setting. So this was a prospective study. It was observational. It was done in a single center trauma ICU. They had about 200 or so, a little more than 200 patients, and they just enrolled everybody they thought was high risk that got a TEG. So got this lab value performed essentially. 35 of those guys got TXA, which is the thing they're using as their actual variable. And then they look at a bunch of, they say that their main outcome was deaths due to bleeding, but mostly they looked at a bunch of other variables, including this. So a ton of different stuff that they were looking at there in only 35 patients. Of note, they also got weekly DVT ultrasounds, which we don't have any report that like anybody in CRASH 2 or any of the other TXA studies actually got. So not only if you developed signs or symptoms of a DVT or a PE, it was just if you were there, you were getting an ultrasound once a week, which may increase the sensitivity for picking up DVTs. But again, we don't know if that's if we're picking up the ones that we really care about. There's lots of data points. There's too much to kind of go through. Just know mostly that. Let me skip over all that. Folks that got TXA in this study, when you go through all the, it's mostly table 1. Folks that got TXA were sicker off the bat. They got more blood transfusions, more cryoprecipitate, more platelets, more plasma, more of everything off the bat. They had more pressors, and they were associated, the folks that got TXA were associated with a higher risk of fibrinolytic shutdown, which doesn't necessarily mean that the TXA caused it. It's just an association right now, because you remember, these guys are sicker. So is this something that TXA is doing? Is this something that just being sicker is doing? Of note, nobody saw the hyperfibrinolysis that's supposed to happen in trauma, which is sort of curious. But also there was no change in thrombotic events. There was no change in mortality. And the TEG, interestingly enough, happened after they got the blood products and the TXA, and the time to it was about 26 hours into the hospital. So after you did a bunch of stuff, then they got the phenotype and they stratified the person out in terms of what they were actually doing.
So once you gave not one variable, but a ton of variables.
There's a lot of stuff. Yeah, there's a lot of stuff that happened. And just again, here's the quick rundown for folks that the different phenotypes. If you weren't in fibrinolytic shutdown versus were in fibrinolytic shutdown. So TXA was associated with more folks that TXA was associated with more folks that were in the fibrinolytic shutdown phenotype. That was statistically significant. However, the rates of clots were exactly the same. The mortality was exactly the same. The hospital stay was exactly the same. The ICU admission rate was exactly the same. None of this was statistically significant, which brings up the point, who really cares then what their lab phenotype is? Because it doesn't seem to be making any difference. Now, that's sort of a simplistic way to look at this because it might make a difference, but this is a small number of people. I've already talked about how it's, we're talking about 35 folks versus 40,000. And 40,000 was just enough to detect a little bit of a difference. Mm-hmm. So who really knows? But to a large extent, almost again with this one, who cares? Well, everybody cares because it's affecting policy at this point. So if I can make a point, it is that TXA seems to help prevent death from bleeding. And the longer you wait, the less it works. And if you're going to give TXA, and in my opinion, you should, in folks that you think are going to bleed, are going to be at risk to die from bleeding in trauma, or probably within a bunch of other stuff, we just haven't looked at it, you should do it as soon as you can, because every 15 minutes that you wait decreases the effectiveness.
It's the same opposite of TPA. I mean, there's lots of bad things that can go wrong with TPA.
Yep, exactly.
But yet, oh yeah, we got to give it. We got to save all the stroke patients.
And I think there's actually better evidence. By the way,
I mean, you could say the same thing about this guy. You could say the same thing about beryllium. I mean, all these drugs we gave for years that now we're like, why did we give that? And then 15 years later, it's kind of like the latest craze of tourniquets. Mm-hmm. Oh my gosh, I remember. Do not, I remember when I first got into EMS, tourniquets. Then do not ever give, do not give tourniquets. Now we're back to tourniquets. Every American needs to have a tourniquet.
Yeah. And I think the difference here is actually that, like, compared to TPA or anything like that, this one's actually got decent data behind it that shows that it's effective, as well as 50 years of clinical practice that say it's actually safe and does what it's supposed to do. But my main thrust is not to necessarily make fun of the trauma guys or anything like that. But it is the problem is you got a study that looks like that. That's really not a very good study and doesn't really show what it purports to show. But we're making policy decisions based on it when we have lots of other data that says actually that's not the case at all. So if I can push anything else out to you, especially EMS guys out there, read the study that you're supposed to be, citing or working under, because you may find that your interpretation of it is markedly different than a policy group's or, mine or anybody else's.
So who goes to the Kentucky Board of EMS and says, hey, what about this? I mean, well-educated, people like from UK and says, hey, I understand, but there's all this other good data that says we should do this. Be proactive on it.
Well, that's a tricky question. Let me answer
it's
it
a political
politically.
question.
Let me answer it politically in saying that everybody is invited to the medical oversight committee meetings, who are the ones that make this, if they're having the meeting that day, and if you can find out when it is.
Yeah.
You are welcome to go to it, and anybody can bring that up. But
there's only, I would argue, there's only a select few probably within the state that actually truly know all the studies, the ins and outs, and can make a an intelligent argument on the data.
You're probably right. I think you're.
As presented, this seems like probably one of the worst interpreted, poorly done studies that I can imagine when comparing it to Matters and Crash 2. I mean, it's small in patient number. It looks at TXA way after all the data tell you to give TXA. So it's not a very good clinical picture at all as to how TXA should perform and how you should interpret TXA's use. Somehow we're anchoring on this study in making our state policies, which, I mean, I'll leave it to other people to battle that out. But is this something that's happening nationally, or is this something that we're only seeing in our state? Like, how impactful is this paper going to be across the trauma literature nationally?
So let me answer the first one. So how
My
impactful is it?
argument is there's the big difference between what you all know and how it gets translated to EMS, because you only have a couple of docs that are influential that are going to be able to make a statement on behalf of the entire state EMS.
Sure.
And who knows if they're very active in practice and up on this particular part of the literature, or have asked for experts from U of L or UK.
In terms of its impact, so this was presented at, I think AAST is the American Association for Surgery or Trauma. So this was like a decent sized meeting, and this was like one of the big research papers. If you go to a meeting where people get to stand up and present their stuff, this was one of their more impactful ones for the year. Which raises the question in my own mind, like, am I misinterpreting this? I don't think I am. I mean, maybe there's something they didn't put in there, but like, I think I'm pretty spot on.
I mean, how many patients you said you had? 218?
218.
That's
But it's significant. It's statistically significant.
I don't think it's clinically significant. I mean,
Well, I think I think if there may be some clinical significance to it, but I think that the numbers, like if you, again, flip a coin 50 times, there's a decent chance that you'll end up with more heads than tails, and that may theoretically look
like this
more
powered to give you anything other than a chance outcome.
Yeah, it's sort of a strange paper, but my point is it doesn't mean anything. Like it changes a lab value, it doesn't change a clinical outcome. But it's driving stuff. So, and in terms of regionally, like Southwest Ohio was super big on TXA. It took us like, when I was up there as a fellow when they implemented their TXA protocol, and it was about a 5-minute discussion in the protocol meeting one day. They're like, hey, do you guys want TXA on the ambulance? Everybody's like, yep. Okay. And like that was it. Whereas in Kentucky, it was easy year battle trying to even get one protocol done. So there's a lot of regional variation on it. And again, there may be other stuff that is important, but I don't think so, at least as far as I can tell. So cool. All right, everybody, let's take just a minute here, and we'll get set up for Dr. Humphreys.